Well, it's a great pleasure for me to introduce our visiting professor today, who's Dr. Jennifer Thornton. Dr. Jennifer Thornton. Interestingly, I didn't know up until a few minutes ago that Jennifer actually came from and grew up in St. Louis, Missouri. And the fact that she reminded me, we met in St. Louis, Missouri when I was at Washington University. At any rate, it's a great pleasure to have her here. Jennifer is currently the Director of Ocular Immunology and Uveitis at the Wilbur Eye Institute. She went to the University of Virginia, where she got her Bachelor of Science. I'm sorry, William and Mary?
Yes.
It was William and Mary, where she got her Bachelor of Science, went to medical school at the University of Virginia, got her PhD in epidemiology in the School of Public Health at Johns Hopkins University. She then did her residency at the Shea Eye Institute, and after that continued in both a faculty and a fellowship position, both in ocular immunology and epidemiology at Johns Hopkins University at Wilbur Eye Institute. And I think since 2002 she's been on the faculty there. And is currently the director, as I mentioned, of the Uveitis and the Ocular Immunology section. And it's a great pleasure to have Jennifer visiting with us today. She's going to, her first presentation is entitled Juvenile Idiopathic Arthritis and Uveitis, and she'll also be giving us the seminar at 11 o'clock. Jennifer, please.
Thank you. Perfect, thank you. Good morning. Thank you, Hank, for the introduction and for inviting me to speak today. One of the things I've learned is it's good to stick with something you know. And this is a disease that we see quite a bit of, and I've seen quite a bit of over the last 10 to 12 years. And we've done a fair amount of research over that time period, clinical research, and also have some ideas of where we want to go from here. And so I thought I would start with sharing that with you. Just to give you a little bit of background, uveitis is uncommon, although a lot of people are surprised when they see what the prevalence and incidence rates are, because they're maybe not as rare as one might have thought in years past. The best data we have is probably currently is out of the Northern California cohort. It puts the prevalence around the 100 per 100,000, and incidence is probably right at that midpoint, right around 30 per 100,000 per year. There are a bunch of syndromes, but the main ones constitute about 25 to 30 different syndromes. And often we tend to classify them by where they're located in the eye and whether or not they're infectious or non-infectious, and whether or not there is a systemic disease that you also need to worry about. Juvenile arthritis is something that you mainly see in the Northern Americas and in Northern Europe, although there are some Southern European countries that are starting to report and discover that they have quite a bit of JIA as well. Interestingly, Asian populations, not as much. And those incidence can give you an idea of where the prevalences are. A lot of the prevalence of arthritis here is about similar to what you see in UV in general. There have been 3 classifications systems, and right now what we're using is this last one, developed by an international league of rheumatologists, basically, which divvy up the JIA into these categories. There's also an undifferentiated category that's down here on the end that I didn't include. Oligoarticular, which is the one we tend to worry about, that's the one with 4 joints or less, has actually been divided into something called persistent oligoarticular and extended. And what that means is basically persistent is after 6 months of the disease, your number of joints or your joint count remains stable over time. Extended means the children that after 6 months develop more than 4 joints, so they go into a polyarticular type of presentation. This is information that is from an Italian group, which I've always found very interesting and actually true, at least in our referral setting. There are some people that contest this, but that ANA positivity seems to be the risk factor over and above the type of arthritis. So if you look here, this is chronic anterior uveitis. You see that if the ANA is positive, regardless of the type of arthritis, it's about 30%. If you've got ANA negative, it drops. And in fact, we are seeing that more. So we're seeing more patients with polyarticular disease that are ANA positive that develop chronic uveitis. For reasons that are not clear, sometimes their chronic uveitis is actually unilateral. I believe this is Aniki Rothrova's group in the Netherlands showing the duration of arthritis and the cumulative risk of uveitis over time, and you see that the curves not only are very different, but they're very different from the start and remain so throughout the duration of the arthritis. The other thing that's sort of interesting is they get very flat at about 5 years, which also seems to be a common theme. About 90% of children will develop their uveitis within the first 5 years after diagnosis of arthritis. So that seems to be the point in time when the children are at greatest risk. It's not to say that it can't happen, it's just that the majority happen during that time period. If you look according to time trends, older studies consistently record 25 to 30%. The Italian group was a retrospective study, so that group was published in 2005 and looked back at people that had been diagnosed in the 80s and the 90s. When we look at population-based studies like what they've done in Canada in the late 90s, the population-based studies suggest a lower rate, also in Germany. 13 to 17%, and it's held sort of consistent. And one of the questions that people are asking now, well, is this difference because the way we treat arthritis has changed? So rheumatologists now are more aggressive and more likely to introduce a drug like methotrexate to treat the arthritis earlier in the disease course. And what many uveitis specialists have wondered is if you introduce a disease-modifying anti-rheumatic drug or a DMARD early in the arthritis, do you somehow alter the likelihood of developing uveitis? Risk factors have been quoted and requoted and really haven't changed much, with the exception of that it appears that ANA may be one of the more potent players here. Younger age arthritis girls, some studies suggest the oligoarticular, but it seems like that's changed over time a little. And as everybody's familiar, probably, the typical case of JIA uveitis is this sort of insidious, wide-eyed, bilateral chronic uveitis that requires screening to pick up, because often kids can be diagnosed as early as 1-2 years of age, and quite a bit of damage can be done if patients are not regularly screened. And this is what the screening pattern has become. This was updated from the 1992 version. This is published in Pediatrics in 2006. And if you look at ANA positivity, age of onset, very important still. Short disease duration is also very important, and then number of eye exams per month. It hasn't changed that much with the exception of adding the duration of the disease. So patients that have been followed for longer than 5 years or so are thought to be at lesser risk. So this represents about a quarter, we estimate, of all pediatric uveitis. You'll see some sort of outlandish numbers in the literature, like 75%, but I think that's probably practice specific. There's a nice article that I'm not getting into that just looked at pediatric uveitis in general that came out of the NEI and Chicago Janine Smith was the first author, and it kind of gives you an idea of what the common players are. But particularly for bilateral disease, JIA is the most common. And it seems to be gaining ground in the unilateral as well, over and above that seen with B27 positivity. This gives you an idea of the ocular complications over the duration of time. And our numbers flattened out around here as well, which can be a little disheartening. This is during the on watch, basically, from the group in the Netherlands. So over the time here. The difficulty here is it again was retrospective. So a person could come into the study being referred at 4 years of duration of uveitis, and the damage was already done. And I have some information that's later in this talk where we've gone back and started to look at, well, what happens if you didn't have any ocular complications when you showed up at a tertiary care setting? What's the likelihood that you will get any ocular complication? That means cataract, like new onset cataract, trace PSC, abnormal IOP, hypotony, or a pressure over 22, any type of band keratopathy, including peripheral macular edema, etc. So we got pretty picky about and pretty conservative about what a complication was. And actually, you're half as likely if you start at a referral center, not just Hopkins even, so I'm not even tooting my own horn, but you're half as likely to get an ocular complication if you come in without any when you start. Now, whether or not that's just the severe people have already, run their course and they come to you late, or whether or not early referral is really making a difference is still too soon to ferret out. But it's promising. Glaucoma is one of the things that probably we worry about more than anything, and probably should worry about more, because children with JIA tend to get a lot of glaucoma, and it can be very difficult to treat. Often you're looking at kids in the 5, 6, 7 range with tubes. I have a current person that we've been following for more than 10 years. She's now 17. Her tubes are 8 to 9 years old, and they're starting to fail. And so you can imagine that this is a kind of an issue that she's going to have to live with for decades, basically. So be wary. These are old outcomes, but I'll give you kind of an idea of where the trends are, and you see some of them are starting to get better over time. The tricky part about these data are these are frequencies, and so they don't take into account the follow-up time or the person time at risk, and so they may be a little bit skewed because of that. This is actually from a group, Clyde Evelston, who's on Ormond Street in London, and he's done a lot of looking at clinical outcomes according to severity risk, which is something that we've started to get interested in. And one of the things he seems to, or this is his big drum, is basically any other complication or presentation doesn't really matter. It's whether or not you have posterior sneaky eye when you walk in the door that kind of communicates to the doctor what type of disease course you're going to have. And this is a proportion of remission over time. And this is years of onset, and yes, that's a typo. That should be 10, but that's actually 20 years out. So he has a lot of data on these children. It's a large group of children. What he means by remission is getting them off drops. Okay, so no med and completely off of everything. And he is both a secondary and a tertiary referral center, so he sees a larger spectrum of kids. So the encouraging thing we see here is that children with milder disease, they do seem to quote-unquote burn out without causing a lot of damage. The running joke, at least Hopkins, was you never wanted to have a patient that burned out their uveitis due to JIA, because really what it meant was there was just nothing more to inflame. The eye had just basically gone pre-tisical and was a very, very sick eye. There was no real useful vision, but hey, there was no cells in the eye. And so parents will ask, well, will the disease ever burn out? And we still kind of shudder and say, well, let's not talk that way. In this case, with some of the milder spectrum that we might not see as much, there are kids that seem to be getting off the drops and doing quite well. However, patients with Sneaky Eye, he found almost 90 to 95% of the case that those kids were chronically on at least some form of medication, even if it was very low dose topical corticosteroids. So I don't know if current is the right word, but these are the things that we've been looking at over the last decade. Not just the clinical outcomes, some of the things that I just described before from some of our colleagues, as well as visual loss, but can we measure any effect of using immunosuppressive drug therapy? Because these are fairly young kids and you're exposing them to drugs that have toxicity, and are you really affecting any change in terms of their ocular outcome? We also really wanted to look at the risk of cataract development because although cataract surgery is quite well tolerated in adults and even adults with uveitis, it can be kind of tricky in kids, and it can be very tricky in kids with JIA uveitis, and some of those patients can do quite poorly. And then the last thing is this idea of trying to figure out if we can identify who's really going to require aggressive treatment earlier in the disease course to prevent loss of vision or the development of some of these complications. Because ideally what you'd like to do is get them controlled before they develop a cataract so that they don't have any visual loss, so you don't have to worry about the risk of amblyopia, you don't have to think about whether or not you're going to put an IOL in an eye. No cataract, no problem. So that's where we've been going. About 2005, 2006, we identified 75 patients, and this is sort of their demographics. You can see that they're kind of typical of your JIA people. Most of them have anterior disease, most of them are female, most of them are white, most of them have oligoarticular disease. The thing that I want to draw your attention to is the median duration of uveitis at presentation was actually 6 years. So 50% of patients had had uveitis longer than 6 years when they walked in to Hopkins to be seen for the first time. And that may actually affect a lot of the severity of the disease that we see and tend to see still. We had 70% were ANA positive. Important to note that that means 30% are ANA negative. So it does happen. A third of the eyes had 20/50 or worse, and a quarter were actually blind. A large number of them had cataract at the time they presented. An equal amount had already had their cataract removed. So up to about 50% of patients had had a cataract one way or the other. And I think that also correlates with the disease duration. We saw an enormous amount of complications. 2/3 had at least one ocular complication when they walked in the door, and almost half of them had active disease as defined as trace cells or greater. There are some, there is some controversy of whether or not we should define active disease as trace or higher versus 1+ or higher. This is the Sun preferred or Sun recommended definition, so I tend to stick to that. But you'll see that a lot of the risk is much stronger as you go to 1+ inflammation. And we have seen some changes in our trends basically prior to 2000 and later. What it looks like is we're seeing more atypical cases, ANA negative cases. We're actually seeing more people aggressively treated, but ironically they're also having more complications. We're getting patients earlier in their disease course, but they appear to have more severe disease as well. If we look for risk factors for, this is definition of visual impairment in this country, definition of blindness. None of these are particularly surprising. The huge risk is if you've been operated on before you hit our door, you've got severe disease and you're not necessarily doing well. Prior surgery included, band keratopathy chelation, as well as cataract surgery and glaucoma surgery. Now, this was one of the things that we found on initial look that was sort of interesting. This is actually at presentation. We found if the person walked in the door having been treated, particularly if they were currently on treatment when they walked in the door, that they were much less likely to be visually impaired. That there was not something seen for 2200 or worse, which may be the situation that we see in a lot of uveitis. If you've already gotten to that 20/50 or worse marker, your risk is much greater to get to 2200 than all comers. And so the reason why this doesn't show up, there may be a treatment by indication bias. In other words, those are much more sicker eyes. They're being exposed to the methotrexate. They're already quite sick. They have a higher risk regardless. Hard to say. But this we found encouraging. We looked at our decreased causes, and we had found no real surprises. Cataract, central band keratopathy, glaucoma. Glaucoma perhaps being the most worrisome one because visual loss would be considered to be permanent, but these are reversible. So somewhat, or potentially reversible, I guess I should say. So we were somewhat encouraged by that. When we went back and we also looked at age of the patient at the time in which the complication was found, the median age was about 9. And so we felt fairly reassured that the majority of amblyopia had been dealt with by either us or referring doctor when we looked at this analysis. And we also looked at rates. So the likelihood of per person per year or per affected eye per year, these are high, okay? On anything above 10, you really don't want to tell your patient, well, you have a 4 out of 10 chance of having a complication in the next year, any complication in either eye. Okay, you have a 1 in 3 chance for each affected eye. So 1 in 3 chance of your right eye developing a complication, a 1 in 3 chance of your left eye. They're not great odds. When we looked at the risk factors for developing vision loss over time, these are people that didn't have this visual loss when they walked in the door, and we followed them to see what happened and who was at most risk. And you can see here, these are the ones that were controlled for all other factors. And they're really not all that surprising. You've got an abnormal eye pressure, you've got flare, you've got active disease, you've developed posterior synechia, you're ANA positive. And the associated or the presumed cause of the vision loss was actually relatively similar over the follow-up time as it was during presentation. So basically saying the common offenders are the common offenders. So we found that the morbidity was quite common. We found a group of risk factors which got us thinking, well, maybe if we can identify a certain set of risk factors early on in the disease, maybe those are the people that we should focus treatment on immediately. And we found that cataract and band keratopathy were quite common in our group, followed by glaucoma. How am I doing time-wise? I go good? Okay. So one of the other things we were, as I was explaining, we were looking at was cataract. Are there things that we can do to lessen the development, prevent the development, prevent the hastening of the worsening of the cataract over time, those sorts of things. And this stemmed from a conversation that we had that involved Steve Foster and others at a meeting. And the question was, you have a 3-year-old child with bilateral disease who is controlled on maximum methotrexate, 25 weekly, and 3 drops a day no, 4 drops a day of Pred Forte. And they have a slight cataract. And the question is, do you continue to taper? You've tried to taper, and you can't get lower than that. And the question was, do you introduce this 3-year-old child to Remicade to eliminate the steroid drops? And Dr. Foster said yes. And there was screaming, and there was hair pulling, and there was all kinds of stuff. So then we took a poll. And it was very interesting because each of the specialists had different thresholds for when they would pull that trigger. And a lot of them really wanted those steroid drops off completely to avoid ocular hypertension, but also to avoid cataract. And the majority of people thought that twice a day would be acceptable, but there were a significant handful of people that thought that no drops were acceptable over the long-term period. And we didn't really define long-term or anything, but it was a very interesting question because personally I thought 4 times a day of Pred Forte with some methotrexate sounded a lot better than methotrexate plus Remicade, particularly in a 3-year-old. So we went back to this data set and we said, okay, well, let's see if we can answer that question. Let's see if we can figure out what the rate of cataract development is among our patients at different doses of steroid and control for active disease and some of these other things. So you already knew that we're going to lose half of our group of patients, or half of our eyes here, because they already had cataract. And we did go back and look at risk of cataract surgery if we could, but the number of cataract surgeries were actually quite low. So we've got this group. We know what the vision loss is. We know that cataract accounted for about 2/3 of the blindness or the definition of blindness in our eyes. So we knew that we had enough cataract there to look at. So we started to think, all right, so what's the overall incidence? And then what would be the risk factors for getting a cataract, and what's the effect of the topical corticosteroids? And is there a safe dose? So you know all this. It's the same group of people. And we looked at, let's see if I've got cataract incidence on here. Oh, I didn't write it down. Shame on me. We looked for the risk factors of cataract, and we found that active disease, posterior sneaky eye, current topical corticosteroids were all big risk factors. Now, you look at this and you go, holy cow, this is probably a marker of severity of disease. Even though this looks like small peanuts compared to that, in population-based medicine, a relative risk of 2 is actually huge, okay? Some of those numbers get kind of falsely inflated because you just don't have enough eyes, enough patients, enough follow-up time to really get a good idea. But these were all statistically significant and strongly so. The other thing is that what we tend to preach, well, you know, it's a two-edged sword. You can get a cataract from treating the uveitis with topical steroids, but you can also get a cataract from having active disease, and lo and behold, there you see it. And actually in this group, you're 3 times more likely to get a cataract for active disease than you are for treating, okay?
What about ANA? You saw no correlation?
ANA was no correlation. These were the ones that were statistically significant when you looked at the variable one at a time, univariate, and then throwing these in with some demographic factors yielded these being statistically significant.
So again, posterior sneaky eye more than ANA would predispose to complication.
And it's interesting because there are people like Clive. I mean, that is a drum he has beaten on for years and years, but it's actually quite remarkable sometimes where it just keeps coming up, you know, and in not just our database, but other people's database. So there's definitely something about having a strong enough flare of uveitis to cause the iris to stick to the lens capsule that is a harbinger of badness. So we had 60 eyes, 40 patients that received topical therapy with follow-up. We had a median follow-up of 3 years and a range that's extended from 6 months to 15 years, because we wanted people to have at least 6 months worth of follow-up. So we did hone down this group of patients to look a little bit more carefully. And here's what we started to find. If you were on Pred Forte greater than 3 drops daily, that was your incidence of cataract. And there's your 95% confidence interval. If you go to 3 or less, it drops way down. And actually, we did 4, 5, 6, 7, 8. And there was a little bit of a dose response up in here, but it never went above about 25% per eye year. And the confidence intervals all overlapped. Okay, so it was fairly consistent, but a huge drop off at 3.
How do you know cause and effect? I mean, maybe kids with more inflamed eyes are getting more cortisol. I mean,
it's a great question. I'll get to that. I'll get to that. Some of it you can't know because of the way the data are collected. You would want perspective, and you'd want, you know, more defined intervals to look at, and you probably want a better way of assessing cataract than just clinical assessment. By the way, this was any cataract. So trace PSC, 1+ NS, 1+ cortical change.
So when you say number of drops daily, as you know, patients, you increase and decrease, increase and decrease. How did you calculate what the
exactly
drop doses were?
We had to make an assumption. So we did them as month blocks. We're pretty emphatic. We're pretty emphatic about seeing them monthly. And so what they were on at one visit was carried over to the next, was carried over to the next. And so instead of going like this, we did sort of the stair-step pattern. What the statistical program, however, does is sort of summarizing the area under a curve or the area under the steps. And so we thought that that was probably relatively good science. The other thing I wanted to show you is if we got to twice daily, which was one of the places where a lot of the uveitis experts favored getting to, we didn't have a single case of new onset cataract. So this isn't cataract affecting vision even. This is just doctor saw it, okay? So we started to look at if we could do a risk analysis here. We took that sort of threshold where the rate seemed pretty high and it dropped down. And we used that as one of our variables, so 3 or less. And we saw that there was a rate reduction that was statistically significant, okay? We controlled for any other type of corticosteroids, so if they were on oral, IV, if they got any injections, those sorts of things. For injection, we counted over a period of 3 months. We looked if they were using immunosuppressive drug therapy because we thought that that could be an indication of disease severity. We also looked at active disease. None of these changed this. And actually, what I don't have on here, which I should, is when you control for presence of posterior synechia, it also does not affect that estimate. So what we found with this sort of quick and dirty analysis is that there seems to be a threshold whereby patients that have higher dosages of Pred Forte or any sort of topical corticosteroid, in this case it was mostly Pred Forte or prednisolone acetate that was being used, have a higher incidence at above 3. And that seems to hold even if you control for episodes of having active disease. So we don't know, we're not 100% sure how many people are actually using this data, but what I tend to tell parents is if they're on 3 drops a day or 2 drops a day, I say we can stay there for a while. I'm not as worried that you're going to develop a cataract on this dose, but I'm only sure for about that medium amount of follow-up time, on that average of about 3 to 4 years, because that was the period of time we observed. The other thing we would like to do is, now as the cohort is growing, is to go back and then start to look at ocular hypertension, need for glaucoma medicines, because it may be that twice daily prednisolone acetate increases your risk of developing ocular hypertension, and so there may be other reasons for wanting that dose lower. So next thing you do, a typical kind of researcher, if you've found things that you think are interesting, you go and you find a different data set to try to prove them wrong or prove them right. And this is another data set that I've been working with. This is actually an R01 that John Kempen at UPenn has, and it's called the Systemic Immunosuppressive Therapy for Eye Disease Cohort Study. And it's 5 centers. It's UPenn, Hopkins, NEI, KCI Institute, and Mercy. And it is basically any patient with any ocular inflammatory disease seen from the inception of the institution until, in this case, 2005. Every single visit, each eye recorded and dumped into a database. So it's what we collected our JIA patients on, but 5 more groups of people. And so we identified 327 children that met the diagnosis of JIA in that database, and that yielded almost 600 effective eyes. And so this is what we found, and this is not published yet, but is submitted for consideration. We found similar incidents of visual impairment and blindness across these 5 referral-based centers. These numbers did not change much if we pulled all of the Hopkins data out. Here was when we were curious, well, you know, we're always harping, you know, send us your patients as quickly as possible, send us as quickly as possible. So I thought, well, let's see if we can figure that out. And sometimes with JIA, it's better to look at complications as a thought of duration of disease rather than actual duration of disease, because you never know. It depends on how well they were screened. So a patient that has 2 years of uveitis may have really had uveitis for 5 years and just didn't have, you know, access to care. So walks in the door with very severe disease. So we went with, instead, whether or not there was an ocular complication when they came to our clinic. And we found that the incidence of developing an ocular complication under observation was twice as high if they had already developed a complication before. So the patients that we were getting that were relatively pristine, regardless if they had active disease, were less likely to develop complication over time. Risk factors we found were exactly the same. Effective immunosuppressive drug therapy over time, relative risk was protective. This is all immunosuppressive drug therapy. The suggestion is methotrexate is quite good, cyclosporin not so good, biologics very, very good. Not enough data really to examine the biologics yet, but that's a goal of this data set in the upcoming 5 years. We also found a suggestion of a protective fact for 2200 or worse, although the p-value, as you can see, the confidence interval included 1. And this, we were able to control for things like vision on presentation in this group of people because we had enough patients to do those types of analyses. So there is at least a suggestion that we're doing right in terms of using immunosuppressive drug therapy to help control these diseases.
And did you look at the subsets that came to you without complications versus complications for the last analysis?
You know, that's a great idea. I will. Yeah.
Because they're very, I mean, that may be by your 0.8.
Yeah, that's actually a nice idea. I don't know if I've got enough numbers. I would assume I would, though. the problem sometimes with doing retrospective data is you're trying to avoid doing the total data dredge, even though you really are. There are certain statistical rules that you try to follow. So in other words, if you throw a confounder in the model, you need to have X number of patients to go with that, so that hopefully something comes out of it that makes any sort of sense. Lastly, I think I still have a few minutes. I wanted to just briefly share something that's sort of that we've been toying with now for about 5 years, I would say. And that is trying to develop a uveitis severity score. So an index perhaps of, you look at simple things that you would see on exam, rate it from 0 to 4, and patients that have higher scores are patients that you would want to immediately put on immunosuppressive drug therapy and see if that correlated with better outcomes. So this is very difficult to do when you've got a small group of patients, and that's why we're not only expanding our data set, but we're testing in other data sets as well to see if we can develop something like this. We started to think about what components we saw that tended to be bad harbingers, and obviously the most obvious one is posterior synechiae, but we also saw problems with abnormal IOP, either hypotenuse or elevated, development of peripheral BK, and flare. Flare has been a tricky one, and we're still working on flare, because it seems to only really hold in the model if it's extreme flare. And I don't know if you've all tried to measure flare, but often, you know, it's very skewed to, it's either 4 or 0. You know, people don't necessarily know what to do with the middle numbers. Although there are flare meters and things like that that people talk about, they're still expensive, and not a lot of centers have them, including Hopkins. So we looked at the correlation with vision at presentation, and we used something called receiver operator curves. What those do is they show you where sensitivity and specificity are maximized. So if you're trying to get a test, or you're trying to develop where a cutoff point is, you can look at the sensitivity of that cutoff and the specificity of that cutoff, plot them in a graph, and determine where you've got the best exchange of the two. And so when we combined these components, and we looked at tons of different components, but when we combined these, a score that was 2 or greater appeared to maximize sensitivity and specificity for poor outcomes. And this is what I mean by that. So if you had a score of 2 or greater, you were more likely to have a longer duration of disease, ANA positive, have prior surgery, have any ocular complication, and these were highly statistically significant. This is just baseline, though. Okay, so this is just the beginning of the trick. Cataract, having aphakia, having any kind of cataract surgery, having any elevated pressure, having an epiretinal membrane. Now, some of these that we put in here were actually part of the definition, okay? But they may have, the reason we included them for twofold. One is they may have only had that and not had any of the other factors. And so it's possible that somebody with a history of IOP could be over here in the low scoring group as well. It was also a bit of a test to see, you know, if it's sort of a cross-check. Okay, well, is the program that we've set up really picking up these attributes and really putting people in the correct bins? And here's what we saw with the vision. So it separates out the vision nicely, and that's really what we wanted to do, but we want to be able to do it over time. And so then we started to look at the rates of developing things that we knew potentially caused vision loss. And there was decent agreement here, but as you can see, some of the numbers start to sort of degrade. And if you notice here, you do see an effect. You see a greater rate in the patients that had the worst score, but they were not statistically significant. And so what we decided with this is, okay, well, this is an interesting concept, but it clearly needs more work. And in order to really get at this, you need very large databases. So one of the things that we've done is we've collected another 5 years of data at Hopkins that we'll test drive this on, and we're hoping to also utilize a group in France, a group out, Gary Holland out in LA, and the site database to then try to corroborate whether or not we're on the right track.
As with your background in epidemiology, excuse me, you know very well that the only real measure in clinical medicine is a randomized trial. And we can massage data for years and years, and we have done that. And then we finally do a controlled trial. It turns out we were going, we're going the wrong direction. And if we could randomize children with leukemia 50 years ago, which we did, we can't randomize children with uveitis?
Well, I guess what would you randomize it to?
Well, that's not my expertise, but you have various protocols that are, some people do this, some people do that, which is best. I don't know about a controlled randomized trial.
I imagine what we could do is if we decided, relative to this research that I was talking about, with a severity index, one of the things you potentially do after you're reasonably sure that you've identified people that have quote-unquote severe disease, that are ultimately going to have poor outcomes if not addressed aggressively. You could randomize that group to receive one or treatment or the other. The difficulty sometimes you have with that, with this type of research is you've kind of created a circular pattern here. You've already decided, well, they're severe and they're going to do poorly. It's kind of hard to randomize them to something that is not aggressive at that point. It's a very good point.
If we can randomize dying children with leukemia.
Well, there's a big difference. There's another major complex problem which Jennifer hasn't referred to, and that is the big question you'd like to know, at least today, is if you saw patients on biologics versus cytotoxic drugs, what would the effect be? You can't do that. I mean, insurance companies don't pay for it, and getting the NIH to pay for such therapy is impossible.
Yeah.
So you can't even do that. I mean, you can't. I mean, that's a major question. You can't do that study prospectively.
Yeah. And the other trouble that we have a little bit with this sort of stuff is there are enough data out there that suggest that using these drugs in severe disease is useful. To try to backtrack and then do methotrexate versus nothing is probably not going to pass a lot of ethics boards. It's a similar thing by why there was never a clinical trial of penicillin for pneumonia. It was thought to be common knowledge that that worked, and I think at least for the majority of uveitis specialists and for rheumatologists, there are enough people out there that their bias is that this works. It's not a matter of whether or not it works. It's trying to figure out who should get it and when. And sometimes those things are very difficult to randomize for because you have a very hard sell, first of all, to a parent to say, okay, well, we're going to hold off on this, because the way you randomize is first you consent them. So you've got to try to sell them on both halves of the trial. It would be easier if you could get the randomization and say, oh goody, you're in arm A, and then just sell that as the thing, for instance, sliced bread. But trials don't work that way, unfortunately, and parents have become very savvy. I think that's all the time I have. We already went over some of the other next steps, but one other thing that might be germane to your comment is that there are some prospective studies that are being entertained. Now, they're not trials still, but there are cohort studies that would be inception cohorts from the time in which the child develops the arthritis and going forward. And that gives us an idea of looking at the risks of developing uveitis and the differences between a group that would be considered controls, non-uveitis, versus uveitis. And that may be helpful. in terms of getting to that question about therapy.
Well, thank you very much. Jennifer, two questions that I have. The data that you have in terms of the incidence of macular edema, how is that obtained? Is that based on OCT, or is that based on clinical examination or fluorescein angiography? What data is used?
That is mostly clinical, and it's a real hodgepodge. If you start to look, there are a couple of people out there that have looked at macular SD-OCT and TD-OCT of children, and they've found actually more thickening and more small cysts, despite there being no real clinical suspicion of there being there. So I think there are subtler changes that are going on there. And it's interesting. I think partly people have become comfortable, well, kids with JIA don't get a lot of macular edema, they don't get a lot of maculopathy, and they've always sort of said, well, you know, the vitreous structure is what it is, and that sort of changes the likelihood of developing, you know, CME early on. I think people are starting to rethink
I would be surprised if one did, you know, an objective evaluation with specular domain OCT. I would be surprised if macular edema was at that level, because I can tell you, after years of looking at eyes with diabetic macular edema and AMD with macular edema, I've come to the conclusion I can't tell.
Yeah.
I mean, if it's terribly severe,
right.
Yeah, I can tell that, but
I think we're very good.
95%, I can't really about it.
Well, I think we're also starting to pick up, you know, we used to deal with macular edema at the 2040, 2050 level, which is a lot more clinically overt. I think macular edema with vision that's 2025, or even refractable down to 2020, is much more subtle, and it's where the technology has been very helpful.
The other question that I had with the database that you've got, what is, and you didn't talk about this at all, is what is the relationship of the recurrent episodes and the chronicity of JIA with articular disease? Is that something that...
I mean, that is that's a great question. We cannot answer that with our database. I'm wondering, I'm trying to think if we could even go back. You know, some of our patients are actually followed by rheumatologists in-house, where the data would be accessible through the computer, the EMR system, but a lot of them are not. And the site database collected almost no arthritis stuff. What's nice, however, is that this prospective study is actually a conglomeration of uveitis specialists, pediatric rheumatologists, and pediatric ophthalmologists. There we will have very precise, we may even have joint counts along with the activity of the uveitis and all of the treatment. And that actually would be very helpful for us to be able to see the correlation.
To get back to John Gammel's question, the only way we can get patients on Remicade or Infliximab is for the rheumatologist to say they have articular disease, even though they don't have articular disease and they have uveitis, which we can't control with topical medication. Because if that's the indication, it's always denied.
Mm-hmm.
Well, so, you know, I can understand that there are many roadblocks.
Yes.
But 100 years ago, people sat down, well, 50 years ago, sat down, parents of dying children, and experimented on their children with their consent, and the cure rate for leukemia went from 0 to 85%. Now, and you know, again, as an epidemiologist, that 10 or 100 or 1,000 database searches could not prove anything. And there are many, as you know better than I, when they finally do a controlled clinical trial, it turns out all that other data goes in the wrong direction. I just find the logic difficult. You say, oh, this is so important, we can't afford to randomize. I'd say it's so important we have to randomize.
John, 50 years ago, if we wanted to, if we did surgery on a pig's eye and we wanted to inject Avastin or something in the eye, or Kenalog in the eye before we, you know, during the procedure, we would just do it.
Right.
Today, we have to get IACUP approval for every single.
Pig eyes?
Are you kidding? For mice, for pigs, for
Yeah.
rats, for anything.
Yeah.
I mean,
It's a very different
it's a
world,
totally
unfortunately. And with kids, because they're identified as a vulnerable population, so much of the regulations are very, very tight.
So basically, we should, I mean, collectively, the system is shooting itself in the foot.
Oh, there's no question.
And there is no animal model for this?
You know, there are animal models, there are experimental models of uveitis. I don't think that there's one that precisely approximates JIA uveitis. But there are some interesting work. One of the things that may be helpful for JIA that parents seem to be more willing to do than the average bear is the genetics research, which I find very fascinating, because a lot of adults shy away from genetic research because of what? It can affect your insurance, it's a privacy issue, those sorts of things. I've found that a lot of parents of JIA are not only willing to put their kid through a stick, but all the siblings, both parents, they'll get granny and grandpa in too. And I think it's because they're very interested in trying to figure out, can you predict if another child of mine will get this? Can you predict if my child is going to get uveitis, and those sorts of things? So I think that we probably have some inroads there in terms of looking at what causes this uveitis and perhaps finding ways we might be able to prevent it in the first place. But I agree with you, trials are going to be challenging. Yeah.
Well, we're going to have to stop at this point, but Jennifer, thank you very much.